Sunitinib is currently one of the first-line agents in kidney cancer. It's an agent that is anti-angiogenic, but also has possibility of immune modulation. It decreases regulatory T cells and myeloid-derived suppressor cells. The vaccine is created from the primary tumor at the time of resection. RNA is extracted from the tumor once the tumor has been taken out of the patient. It is then loaded onto white cells or dendritic cells and then given to the patients as a vaccine in combination with sunitinib.
And the category of patients you're looking at are?
So these are all patients that present with a primary tumor intact and metastatic disease, who usually have intermediate and poor prognosis renal cell carcinoma using any of the standard classifications.
So what was the reason for having a TKI together with this autologous immunotherapy?
So we know that the immune-based therapies in kidney cancer, although being somewhat effective, are not as effective as if given in combination with something that reverses immune suppression. Sunitinib has the capacity to reverse immune suppression, which then makes the possibility of a vaccination strategy more potent.
Okay, how did you test this out? What did you do in the study?
So this was done before the study. Jim Finke at the Cleveland Clinic, our own group when I was at City of Hope, demonstrated that sunitinib changes regulatory T cells and myeloid-derived suppressor cells. And we have an article in Press in the Journal of Immunotherapy of the phase 2 results of the combination of sunitinib and AGS-003 demonstrating immune stimulation, memory T cell generation, and then some patients with long-term disease control.
Could you run me through the number of patients and what you did?
It was a small number of patients in the beginning, only 21 patients. But in that 21 patients, we have now some patients out more than 5 years cancer controlled.
So what happened?
So what happens is you reduce tumor, you induce memory T cells, and you induce an immunologic response that's capable of controlling the cancer for an extended period.
It sounds fairly different and promising clinically. What's coming out of it then?
Well, so that was the premise and the basis for our phase 3 trial. Our phase 3 trial is now going to be in 450 similar patients, clear cell cancer, primary tumors extracted, treatment of the metastatic disease with either vaccine plus sunitinib versus sunitinib alone. We've accrued almost 350 of those 450 patients to date. We expect accrual to complete by middle portion of 2015, and hopefully we'll have a result within a year thereafter.
Now let me get this right, you are seeing long-term benefits?
We are. We're seeing long-term benefits in addition to prolongation of progression-free survival, such that we think we can improve overall survival as well as PFS.
And this is in metastatic disease, not just metastatic, but synchronous metastatic with the primary also in place, discovered at the same time.
Right, so remember the following. It's patients that present with their primary tumor in their kidney, already metastatic to other sites, where we take out the primary tumor, generate the vaccine, and then treat the metastatic sites with the vaccine plus sunitinib.
So it sounds hopeful. We haven't got the results of the phase 3 study yet, but what would you say doctors should glean from the information so far?
Well, be aware of the following. So we spend a lot of time in the field of kidney cancer trying to understand the role of cytoreductive nephrectomy, meaning taking out the kidney in the presence of metastatic disease. If this trial turns out to be positive, we would be generating a treatment from the tissue in the individual patient as a result of the cytoreductive nephrectomy. This is what we would call personalized immune-based therapy, because it can't be given to a different patient, because only the antigens that drive the patient's own tumors are the ones that form the vaccine for that given person.
In which case, it's quite difficult to duplicate this on a large scale.
Well, no, that's not true. I mean, we've accrued over almost 1,000 patients to the trial, of which we've randomized over 340. So it's pretty clear that we have, and this is an international trial taking place all over the world, so it's pretty clear that you can harvest, send, prepare, and return the vaccine wherever the patient happens to be.
So what's the take-home distillate, the clinical message coming out of this for doctors at this point?
So for the population of patients, of kidney cancer patients that present with a primary tumor intact, follow the AGS-003 trial results, because if this trial is positive, then you're going to want to make sure that your urologist who's taking out the tumor is sending that tumor for vaccine development, and then pre-prepared for asking and answering questions in other populations of kidney cancer patients. Because there's no reason to believe that you need the primary tumor to generate vaccine. You could also generate the vaccine from a metastatic site, but that's to be determined.